Bro, just go, bro. Right now, hurry up. Hold on, do it. Yeah, yeah. Oh my God.
To find the iliac crest, you would first find the bony prominences of the PSIS, which is in the inferior portion of the gluteal dimples, which in normal circumstances are palpable and align at the same level. The ASIS is easily palpable in most patients, but may become obscured in muscular or obese individuals. With the patient standing, you can palpate the ASIS. Now that you have the ASIS and PSIS landmarks, the bony prominence that runs like a ridge between the two is the iliac crest. The differential diagnosis based on pain upon palpation of this location would be an iliac crest contusion. To find the patellar tendon, palpate the length of the patellar tendon from its insertion on the tibial tuberosity. The patellar tendon normally feels broad and rope-like. Acrotic tendinopathy often results in palpable nodules within the mass of the tendon. The tendon can also be palpated while the patient performs active range of motion of the knee, noting any crepitus. This can indicate patellar tendinopathy or jumper's knee, which is commonly found in jumping and running sports. Pain can be induced by cutting motions in sports. Extensors are heavily stressed, causing pain during jumping activities. Stiffness and pain can also be observed from just sitting due to inactivity. The dermatome and myotome key points for the patellar tendon is the L4 nerve root level. The reflex can be tested by having the patient sitting with their knees over the table. The patient should be instructed to look away from the tested knee as the examiner taps the patellar tendon with a reflex hammer. To find the navicular tuberosity, palpate the medial malleolus. From the medial malleolus, palpate anteriorly and inferiorly until you feel a raised bony surface. This is the navicular tuberosity. The navicular articulates anteriorly with the three cuneiforms, the cuboid laterally, and the talus posteriorly. The medial aspect of the navicular gives rise to the navicular tuberosity. Traumatic symptomatic pes planus can be related to a fracture of the navicular tuberosity, which may result from an accessory navicular, which is a bony outgrowth which serves as a partial attachment for the tibialis posterior. Tenderness of the navicular can indicate possible tibialis posterior tendinopathy, a sprain of the spring ligament, or a stress fracture. A helpful assessment for this bony structure is a navicular drop test.
For the anterior drawer test of the ankle, I'm going to place the patient in a supine position with the foot relaxed. With one hand, I'm going to stabilize the distal tibia and fibula, and with the other hand, I'm going to grasp the calcaneus of the patient's foot in about 20 degrees of plantar flexion. And I'm going to draw the foot anterior and apply enough force, strong enough to adequately test the structures. And also I'm going to test bilaterally. And a positive sign would be a dimple over the anterior talofibular ligament. And the indication of the anterior drawer test would be a tear of the anterior talofibular ligament.
Faber's test. Patient position, supine with the foot of the involved side crossed over the opposite thigh. Position of examiner at the side of the patient to be tested with one hand on the opposite ASIS and the other on the medial aspect of the flexed knee. The extremity is allowed to rest in full external rotation, followed by the examiners applying overpressure at the knee and ASIS. A positive test is a reproduction of symptoms in the sacroiliac joint or hip. Implications is pain in the inguinal area anterior to the hip may indicate hip pathology. Pain in the SI area during the application of overpressure may indicate SI joint pathology.